Imagine I give you a patient with a severe vomiting. The vomiting is especially after the meals. Now I ask you, where exactly the obstruction and why is the stomach get enlarged? Which part of the stomach is involved and which artery supplies it? Where does it lymph go and which nerves controls it? If you know the stomach as the three-dimensional organ, these questions become surprisingly easy for you. But if you simply memorize and list of arteries, relations, and lymph nodes, stomach becomes one of those anatomy topics that you forgot again and again. So today we are going to build the stomach from the shape, position, parts, relation, blood supply, lymphatics, nerve supply, and clinical anatomy. And by the end, you will be able to draw, explain the stomach without memorizing facts. Before we start, understand why the stomach exists in the first place. The stomach is basically the muscular storage of the processing chamber and between the esophagus and duodenum. And food comes into from above and stay for some time, get mixed with gastric juices and gradually delivered to the duodenum. So, if you understand the basic flow, esophagus, stomach, and duodenum, the entire anatomy starts making sense. Superiorly, the stomach is connected to lower end of the esophagus, and inferiorly, it continues to the duodenum. And anatomically, it is widest and most distensible part of the digestive tube. Now, ask yourself, why does stomach need to be muscular? Because it doesn't simply store food; it also mixes it, and this thing like a washing machine. Food enters, gastric secretions are added, and muscular contractions mix everything together. It acts as a reservoir for food, and it softens and mixes the food with the gastric juice, and gastric juice contains enzyme involved in the digestion. The stomach produces hydrochloric acid, which creates the acidic environment and plays and helps destroy to many microorganisms enter in the body. That's an important concept. Stomach produces acid strong enough to damage tissues, but the stomach itself normally survives. Why? Because its protective layer, mucosal barrier, and the stomach also has some absorptive activity capacity that small amount of the water and alcohol, certain drugs can be absorbed. And finally, the stomach produces intrinsic factor, which is essentially absorption of the vitamin B12 in the ileum. Let's see the location of the stomach. Now let's put the stomach inside the abdomen. Stomach lies obliquely in the upper and left part of the abdomen. Upper and left part of the abdomen. Clinically, think of the regions that epigastric, umbilical region, and left hypochondric region. Most of the stomach is protected beneath the left costal margin and ribs. But here's the something important: that stomach is not rigid organ sitting in exactly the same position all the time. Its shape and position changes with distension and muscle tone. Look at the diagram in empty or relatively contracted stomach is classically described as the J-shaped. But don't imagine the every person's stomach look like the perfect J shape. Its shape changes according to amount of food, degree of distension, and tone of its muscular wall. Then, conceptually, the shape is dynamic but not fixed. Now, let's talk about the size. Stomach is approximately 25 cm long in adult, and it is very distensible organ. That means its capacity changes dramatically with age and feeling. At birth 30 milliliter, at puberty 1000 milliliter, an adult approximately 1000 to 1500 ml. Don't just remember these numbers. The important concept is small organ when empty, highly expandable when filled. Now we are entering the section that university examiners love. That if someone asks, describe the external features of the stomach, you should immediately think the two orifices, two curvatures, and two surfaces. Two. Let's understand the orifices. Two that are the cardiac and the pyloric. This is where the lower end of the esophagus joins to stomach. So food enters through esophagus and then cardiac orifice and then stomach, and the pyloric orifice, that is the now move to the opposite end. This is pyloric end, which opens into the duodenum, and so entire stomach can be imagined as a controlled chamber. Entry by the cardiac and exit by the pyloric canal. Two curvatures, that are the lesser curvature and the greater curvature. Lesser is the concave and forms right border of the stomach. But why it is important? Because lesser omentum attach here, and there's another high yield point, that the most dependent part of the lesser curvature is marked by notch called the angular notch. Here is the angular notch. It is simply notch along with the lesser curvature. Here is the greater curvature, and it is attaches to the greater omentum and ligaments associated with the spleen and diaphragm. And remember that greater curvature, greater omentum, and gastrosplenic ligament and gastrophrenic ligaments. Two surfaces. In distended stomach, we describe the anterior surface and the posterior surface. Anterior surface is faces forward and upwards, and posterior surface faces backwards and downwards. But here's an important anatomical concept. When the stomach is empty, its surfaces can be described more as superior and inferior surfaces because the organ is collapsed. When distended, organ anterior and posterior surfaces become more obvious. So don't blindly memorize directions. Think about the stomach as a flexible organ that changes orientation with distension. Let's see the parts. Four parts are there: fundus, body, pyloric antrum, and pyloric canal from above to downwards. Fundus, it is the dome shaped organ, and above the level of cardiac opening of the stomach, it is the fundus. Body, below the largest part, is called as body, and the body forms a major portion of stomach. Pyloric antrum, this is wider distal region, is called as pyloric antrum, and his pyloric canal, that immediately before the pyloric opening, the narrower pyloric canal. This is the pyloric canal. The relations of the stomach. Now comes one of the most confusing part of the stomach anatomy, that are the relations. Students usually memorize the huge list. I don't want you to do that. Instead, imagine the stomach as a balloon, and it has front, back, coverings, connectings, and its neighboring organs. First, we will see the peritoneal relations. The stomach is intraperitoneal region and is connected to surrounding structures by peritoneal folds. Lesser omentum, that is the from the lesser curvature, the lesser omentum extends towards the liver. From greater omentum, the from the greater curvature, greater omentum hangs downwards. Then the gastrosplenic ligaments from the upper part of greater curvature, and it connects to the stomach to the diaphragm. And gastrosplenic is extends towards the spleen, and gastrophrenic ligament extend towards the stomach to the from stomach to the diaphragm. Let's see the visceral relations. Anterior surface and for the posterior surface. Anteriorly, stomach is related mainly by this liver, diaphragm, and anterior abdominal wall. So if you stand in front of stomach, these are the major structures you should think about. Posterior relations, also called as stomach bed. Now here's the important term, that is stomach bed. Imagine lifting the stomach upwards, that when what lies behind it? These structures collectively form the stomach bed. Diaphragm, spleen, left kidney, suprarenal gland, pancreas, transverse mesocolon, left colic flexure, and importantly the splenic artery. Why the term stomach bed is important? Because instead of remembering the 8 random posterior relations, you visualize the stomach lying on the bed of these structures. And here is one mnemonic, that DSK SPTC. DSK SPTC means diaphragm, spleen, kidney, suprarenal gland, pancreas, transverse mesocolon, and colic flexure. You don't need to force yourself to memorize these letters. Just visualize stomach, lift, and stomach bed underneath. This is the dotted line. It is the stomach, and behind that these structures are there: pancreas, diaphragm, spleen, suprarenal gland, kidney, left kidney. This is transverse mesocolon, left colic flexure. This is stomach bed, and here is the one splenic artery. Let's see the blood supply. Now here's the easiest way to understand it. The stomach lies the territory of the celiac trunk. So the arteries supplied to the stomach are mainly branches of celiac arterial system. There are 6 important arteries, that are left gastric artery, branch of celiac trunk, Right gastric artery, branch of hepatic artery. Left gastroepiploic artery, left gastroepiploic artery, that is branch of splenic artery. Right gastroepiploic artery, branch of gastroduodenal artery, and short gastric arteries, branches of splenic arteries, and posterior gastric artery. These also branch of the splenic artery. Now notice the pattern that along the lesser curvature, here diagram, along the lesser curvature there is left gastric artery plus right gastric artery, and along the greater curvature left gastrosplenic artery and right gastrosplenic artery. And here is the another venous drainage. Now here's beautiful anatomy principle that arteries go in, veins come out, and the venous drainage of the stomach ultimately reaches the portal circulation. The veins correspond broadly to the arteries: left gastric vein, right gastric vein, left gastroepiploic, right gastroepiploic, short gastric vein, and posterior gastric veins. Ultimately, the gastric venous blood drains into the portal venous system. This is the portal vein. This becomes clinically important because the stomach is part of the portal circulation, and the gastric veins can become involved in portal hypertension and varices. Now I want to forgot the lymph node list for a moment. There is one principle: lymph follows the arteries. So if you know the arterial territories, lymphatic drainage becomes much easier. The stomach can be divided into regions, and the lymph follows the corresponding vessels towards the regional lymph nodes. And the left gastric nodes, right gastric or pyloric or pancreatosplenic nodes, or gastroepiploic nodes. High yield areas, that upper stomach, gastric and pancreaticosplenic here, and for lower pyloric and gastroepiploic pathways. Here, students often try to memorize the lymph drainage as isolated arrows. Which artery supplies the part? Which lymph node lies along the artery? That's the logic. Here's the node for the upper 2/3 and lower 1/3, and this is upper 1/3 and lower 2/3. Right and left part divided into two parts. Now imagine the stomach is not just a muscular bag. It has to know when to contract, when to secrete, and how to coordinate its movements. That's where the autonomic nerves come in. The sympathetic innervation comes mainly through the greater splanchnic nerves reaching the stomach through the celiac plexus. Parasympathetic supply comes in vagus nerve through the anterior and posterior vagal trunks and their gastric branches. This becomes especially important when you study the vagotomy, and because altering the vagal input can affect the gastric secretion and mobility. Now let's make all the anatomy clinically useful. First one is infantile hypertrophic pyloric stenosis. Imagine a newborn or a young infant who develops persistent projectile vomiting after feeds. What could happen if the muscular wall at the pyloric region become abnormally thick? Outlet becomes narrow and gastric contents have difficulty passing into duodenum. This infantile hypertrophic pyloric stenosis. Important anatomical abnormality is the hypertrophy of the circular muscles of the pylorus, producing gastric outlet obstruction. So suddenly your anatomy becomes clinical, and pylorus, then narrowed outlet and gastric outlet obstruction. Second one is peptic ulcer, more common with blood group O. And for your exams, know the association as taught as a standard anatomy notes, but don't confuse association with causation. The anatomical point that's especially important is the lesser curvature. Why? Because the lesser curvature contains the gastric arteries, so the ulcer here can potentially erode into the blood vessels and cause the significant bleeding. And third one is gastric carcinoma. Finally, you again remember this is the classical exam association rather than thinking the blood group itself causes the cancer. It is common in blood group A, and bigger anatomical lesson is the gastric pathology can spread through rich lymphatic networks of the stomach, and that's why understanding lymphatic drainage is not just an exam exercise. So congratulations, you have learned all about the stomach, and if you like it, share, like and subscribe. Thank you.